So this is a multi-center randomized trial of the 2-year data of the TALENT study. So we know that there was a recent meta-analysis by Bangalore showing that ultra-thin strut stents defined as less than 70 micrometers in thickness reduce the incidence of target lesion failure compared to the modern generation stents that we used. We presented the data of the 1-year data of the TALENT study, which was a prospective multi-center all-comers randomized controlled trial of over 1,400 patients, which was compared in a non-inferiority fashion to the Xience everolimus-eluting stents in terms of device-oriented composite endpoint up to 1 year, and this was published in The Lancet earlier this year. The current presentation is of the same trial, but at 2 years, looking at the ultra-thin strut Supraflex stent against the Xience stent. These were the sponsors. The funding was from the manufacturers of the stent, SMT, which was an unrestricted educational grant, and the clinical research organization leading this was Cardialysis. And I'm speaking on behalf of my co-authors, Rob DeVinter, Upendra Kaul, Patrick Sarais, and Yoshiri Nomura, and all the other investigators. So what is a Supraflex stent? As I've said, it's ultra-thin. So ultra-thin defined as less than 70 micrometers. This is 60 micrometers thin across all the stent diameters. And this is important to remember because there are other competitors where they are ultra-thin, but in the smaller stent diameters. The Supraflex stent is ultra-thin across all stent diameters, from the 2.25s to the 4.5, and even the 2.0 is 60 micrometers. It's a biodegradable polymer matrix. The drug is sirolimus, 70% released within 7 days, and there's a sustained release over the next 48 days. The TALENT study flowchart was this. We've presented this before. 1,435 patients from 23 enrolling sites. 720 were randomized to the Supraflex arm, 715 in the everolimus arm. The key thing that I want to point out to you, to the audience, is the information on the left-hand side of this slide. This was an all-comers population. There was no selection criteria applied to the type of patients who could receive either stent. It was any ischemic coronary syndrome, any type of lesions, including vein grafts, including CTOs, and there was an unrestricted use of drug-eluting stents. So it's important to remember that this study was reflective of real-world practice. At the end, we had 704 patients at follow-up at 720 days in the intention to treat analysis in the Supraflex arm, and 705 in the everolimus Xience arm. The primary endpoint, device-oriented clinical endpoints, composite endpoint was cardiac death, target vessel MI, and clinically indicated target lesion revascularization. As you'd expect from a randomized study, most of the clinical characteristics were matched. There was this by chance in the Xience arm. There were significantly more at 7.7% patients who had previous CABG. Lesion characteristics, once again, matched as you'd expect from a randomized study. The one difference was that the maximum balloon diameter used to post-dilate the stent was slightly higher in the Supraflex arm at 2.52 versus 2.46 in the Xience stent. And this may just reflect familiarity with the Xience stent that the majority of operators use. So the results at 1 year for the device-oriented composite of cardiac death, target vessel MI, and cardiac clinically indicated target lesion revascularization was this. We found that at 1 year, for non-inferiority, which is what this study was powered for, it was very strongly non-inferior to the Xience stent at 1 year. What happened to 2 years? Similarly, you have the Supraflex in red, you have the Xience stent in blue, cumulative incidence on the y-axis, and time since index procedure on the x-axis. And you can see that out to 2 years, this finding in the 1 year was maintained, and that it remained non-inferior out to 2 years. What about cardiac death up to 2 years in the intention to treat? So there was this slight difference at 1 year, which we could not explain. We felt it was a play of chance, but it was very important to continue following up these patients. And at 2 years, as we thought we would find, there was absolutely no difference in cardiac death up to 2 years between the Xience and the Supraflex arm. Target vessel MI up to 2 years. Once again, at 1 year, no difference. At 2 years, no difference. Numerically smaller for the Supraflex arm, but statistically not different. What about clinically indicated target lesion revascularization in the intention to treat arm? So we found that at 1 year, this was surprising also, that at 1 year it favored the Supraflex arm. And once again, there was no strong mechanism for this beyond the thin strut, but out to 2 years, when we followed patients up to 2 years, there was no difference at all in the target lesion revascularization at that point. What we are worried about for our patients, what we are worried about as physicians, is definite or probable stent thrombosis up to 2 years. There was no difference, and remarkably low rate at 1 year for both stents, and this was maintained out to 2 years. So not only remarkably low, but non-inferior compared to the Xience out to 2 years, and the Xience stent is proven to have a low incidence of stent thrombosis. If we then switch to the per protocol analysis, so this included not intention to treat, but per protocol. So these were patients who received only the assigned study stent. And at 1 year, we had this finding that the clinically indicated target lesion revascularization in the per protocol analysis favored the Supraflex stent. And it was significant, the p-value was significant at 0.021. However, out to 2 years, this difference was not maintained, and both the device-oriented composite events at 2 years and the CI, clinically indicated target lesion revascularization, out to 2 years, whilst numerically smaller for the Supraflex stent, there was no statistically significant difference between the two products. So in summary, Chairman, the Supraflex biodegradable polymer sirolimus-eluting stent demonstrated comparable 2-year clinical outcomes to the leading drug-eluting stent worldwide, which is the Xience everolimus-eluting stent, and this is an important point, in an all-comers population. Patients were not selected. They included acute coronary syndromes, vein grafts, CTOs, everything. The lower rate of clinically indicated target lesion revascularization that was seen in the Supraflex arm at 1 year in the per protocol analysis only was not seen out to 2 years. Thank you for your attention.
Thank you. Questions? We have a couple of minutes.
So the per protocol analysis is actually quite interesting from the standpoint of a non-inferiority trial, just because if you'd use ITT, it tends to make the arms look more equal. So from the standpoint of a non-inferiority trial, we're actually more interested in the per protocol and assigned stent analysis. We noticed that there's a little bit of a step up in revascularizations at 1 year. Do you think this is driven by mandatory 1-year angiography, or?
No, so there was no, it was all clinically driven. There was no mandatory 1-year angiography in the trial. It was all clinically indicated.
Yeah, so the curve's a bit peculiar in that about 360 days, there's this uptick of events in just the one arm. Do you have any potential explanations for why that might be?
No, this is what we found. Could it be because of the, the patient characteristics? Because we had this unexplained event for mortality in the per protocol analysis, which we couldn't explain. I think it's just a play of chance. And the reason I say that is because when you follow these patients, as you've seen, out to 2 years, it smooths out.
Yeah, and that would probably be the expectation, both from what we think about the biology of thin struts,
Correct.
plus if we follow people sufficiently long enough, they're going to have event accrual at a steady rate in both arms. So,
Correct.
We expect the difference to diminish over time.
Yeah.
More questions from the audience? No? I have quick questions out of curiosity. Why did you choose sirolimus?
No, this is something for the manufacturer. I suspect that it's
more available. That's
it's
why
widely available. It's you don't have to buy the product. It's generic, and previously it's shown to work, and previous studies and subsequent studies have shown that it's as good as the other Olimus compounds. But I think the main reason will have been its wider availability.
Okay, thank you.
Okay.
Thank you. So I want to invite next speaker, Dr. Abdel Hakim Alali, who will give a talk, polymer-free drug-coated versus bare metal coronary stent in patients undergoing